Pelvic floor symptoms are highly prevalent in exercising women. Across all sports, 1 in 3 women leak urine, and 2/3 of recreational athletes experience anal incontinence. Experiencing pelvic floor symptoms negatively impacts exercise participation, causing 1 in 2 women to stop a form of exercise, including 1 in 3 young nulliparous athletes. Women are reluctant to discuss their symptoms. In fact, a majority of recreational athletes have never told anybody about their symptoms. Health and exercise professionals commonly screen for general health conditions as part of their role. However, pre-exercise screening questionnaires do not typically include pelvic floor symptom questions. Women may continue exercising if professionals are able to identify and manage their symptoms. So we aim to establish health and exercise professionals' current practice for screening and managing pelvic floor symptoms in women within sports and exercise settings. Between health and exercise group differences, and their attitudes, barriers and enablers towards engagement in future practice. Australian health and exercise professionals participated in a purpose-designed and piloted online survey. Health and exercise professionals who provide advice or management to women participating in any level of sport were invited to participate by their organisation or professional body. A total of 636 participants were included in the final analysis. The highest professional representation included physiotherapists, personal trainers or fitness instructors, and exercise physiologists. They had worked in their current profession for an average of 12 years across a variety of settings, and a majority of participants were women. Participants worked across a broad range of sports, and 15% worked with elite female athletes. Many had accessed training specific to pelvic floor disorders, most commonly a lecture, and 9% in this survey had a pelvic floor specific postgraduate qualification. The majority of participants report that they screen for general health conditions as part of their current role. However, 50% of participants never screen for pelvic floor symptoms. 1 in 4 report screening all exercising women that they interact with, and a further 1 in 4 only screen if they feel it is indicated. We asked participants which groups they feel pelvic floor screening is indicated in, and we found that at-risk groups are not being screened for pelvic floor symptoms. Despite the childbearing years being a period of pelvic floor symptom onset for many women, more than half of participants do not screen postnatal, parous or pregnant women for pelvic floor symptoms. 2/3 do not screen older or postmenopausal women. And 70% of health and exercise professionals do not screen for pelvic floor symptoms in women that engage in high impact exercise or young nulliparous athletes, despite the high rates of sports cessation in these groups secondary to their symptoms. Most participants who screen for pelvic floor symptoms use a verbal question rather than a written questionnaire, and half do not use a specific screening tool or a standardised questionnaire. For both health and exercise professionals, the most common reason for not screening for symptoms is waiting for their patients or clients to disclose their symptoms first. The absence of pelvic floor questions on their organisation screening tool was another key barrier, and a lack of training or knowledge of which questions to ask were also common reasons for not screening. If women revealed pelvic floor symptoms, 75% reported referring to another health professional for management, most commonly a physiotherapist or a GP. Both health and exercise professionals commonly prescribed pelvic floor muscle training, and a majority utilised verbal cueing. And 1 in 2 professionals advise women on modifications or activities to avoid during exercise. Health and exercise professionals agree that questions on pelvic floor symptoms should be included in pre-exercise questionnaires and also on annual sports health evaluations. A majority of participants were willing to include pelvic floor screening in their future practice. And for those participants who are not already screening, a really important enabler was a written or verbal screening tool that could be used in practice. Other enablers included professional development training to improve knowledge on pelvic floor conditions and the indications for screening, and access to resources and handouts for educating their clients and referral options to health professionals. And finally, longer consultation times, and for exercise professionals, a private consultation area. The main limitation of this study is the potential for non-responder bias inherent to self-enrolment in internet surveys. Participants who were motivated to engage in symptom screening may have been more willing to respond, and this may have led to an overestimation of screening rates and the proportion who hold a pelvic floor specific postgraduate qualification. Males and doctors were underrepresented, which limits generalisations of our findings to these groups, and this may be due to a lack of interest, comfort or confidence in pelvic floor symptom screening. Despite a high prevalence of pelvic floor disorders in exercising women, screening for symptoms within sports and exercise settings is not common practice in Australia. Professionals wait for patients to tell them about their symptoms despite low self-disclosure rates. And education is needed to raise the awareness for the need to screen all exercising women for pelvic floor symptoms, especially in groups such as young, high-impact athletes, where the knowledge of impact of symptoms on exercise participation is not as well known. To allow engagement in future practice, health and exercise professionals require access to professional development on pelvic floor disorders targeted at their scope of practice, including indications for screening, screening questionnaires to utilise in practice, and management options and clear referral pathways. Thank you.